Assalamu alaikum. Now I would like to talk about immunodeficiency. Starts with phagocyte dysfunction. This is the picture of leukocyte adhesion deficiency, and leukocyte adhesion deficiency are of two types, type 1 and type 2. Type 1 is very high yield. In type 1 there is impaired migration. In type 1 there is impaired migration and chemotaxis, and we know that in leukocyte extravasation there is margination, rolling, migration, transmigration. These are the these are the sequence of this leukocyte extravasation: margination, rolling, migration, chemotaxis, there is diapedesis. These are the sequence of this leukocyte adhesion. So if there is deficiency of this, if there is deficiency of leukocyte, that means if there is defect in LFA integrin, if there is defect in type 2 leukocyte, there is defect in LFA integrin, where in CD18 there is defective LFA integrin in CD18. So there is impaired migration and chemotaxis of this leukocyte. That's why in clinical feature you may get recurrent skin mucosal infection, but there is absence of pus, because it simply pus means dead neutrophil, and dead neutrophil and as there is no neutrophil is going on to those particular area where the infection is present, that is called leukocyte adhesion deficiency. So there is poor wound healing. And another thing, if a baby has delayed separation of umbilical cord, more than 30 days, then you should think about this leukocyte adhesion deficiency. In leukocyte adhesion deficiency, there is increased neutrophil in the blood, but not in the infection site. That is the main thing you have to remember. Now there are another leukocyte deficiency called leukocyte adhesion deficiency type 2. In here there is problem is in leukocyte adhesion deficiency type 2, the main problem is impaired margination and rolling. Why margination and rolling? Because there is a decreased Sial-Lewis X, and then this Sial-Lewis X present in leukocyte. If there is decreased Sial-Lewis X, this is called leukocyte adhesion deficiency type 2. In leukocyte adhesion deficiency type 1 is most important. This is another way of remembering leukocyte adhesion deficiency absent CD18. This is the baby with leukocyte adhesion deficiency type 1. Look, there is no pus here. He has huge infection near the ear, but there is no pus. Next disease is Shediac-Higashi syndrome. In Shediac-Higashi syndrome, what happens in here? In Shediac-Higashi syndrome, what happens in here? There is a defective LYST, lysosomal trafficking regulator gene. LYST, defective lysosomal trafficking regulator gene. So there is microtubule dysfunction. And in here there is a defect in phagolysosome fusion. This is another high yield point. You have to remember that phagosome and lysosome fuse, and thus an infection is killed. If there is defective phagosome and lysosome, it will cause this Shediac-Higashi syndrome. This is the histological picture with Shediac-Higashi syndrome. Look at the giant granules. This is the giant granule seen on histologic giant granule in granulocyte and platelet. There may be pancytopenia and there may be mild coagulation defect. And the clinical features you have, you can easily remember by a mnemonic called PLAIN. That means progressive neurodegeneration, L for lymphohistiocytosis, A for albinism. This is the picture of albinism, but this albinism should be partial albinism, progressive neurodegeneration, lymphohistiocytosis, albinism. I for infection, and N for neuropathy, and I'm saying it another time. That means progressive neurodegeneration, lymphohistiocytosis, albinism, which is partial, infection, and peripheral neuropathy. And the last disease, this is the picture of chronic granulomatous disease. In CGD, chronic granulomatous disease, there is defect in NADPH oxidase. So there is a decreased reactive oxygen species. There is decreased reactive oxygen species. That means superoxide, and decreased respiratory burst in neutrophil. The previous one is autosomal recessive, but this one is X-linked. Another thing you have to remember. And in here there is infection happens via catalase positive organism. Do you remember the catalase positive organism? Catalase positive organism are all the staph aureus, staph epidermidis, staph saprophyticus. These are all catalase positive organism. And another thing you have to remember that there are two tests to detect this chronic granulomatous disease. First of all, there is nitro-blue tetrazolium dye test. If you give this nitro-blue tetrazolium dye test, it fails to turn into blue. It fails to turn into blue in the diseased person. In the diseased person, it fails to turn into blue. In diseased person. So if the nitro-blue tetrazolium, if the NBT negative, means the patient has disease. If the NBT is positive, the patient doesn't have disease. That is another thing you have to remember. And the other test is dihydrorhodamine test, abnormal dihydrorhodamine test done in flow cytometry. Abnormal dihydrorhodamine test, dihydrorhodamine test. It fails to turn into green, decreased green. So that's all about this phagocyte dysfunction.